So thank you everyone for joining. Again, sorry for late notice, but clearly things move very rapidly in the yeah, thank you, Alan. Yeah, that's great. Moved rapidly in the COVID world. So we knew some stuff was coming, so I wanted to get a summary out today. I've listed there the people doing some presentation components. We've basically got three components. First one is me doing a bit of an update. I'm wary I have public health colleagues on the call and I don't want to make any errors, so please be forgiving. We've then got Jason and Gavin who are going to talk to us about some IPC issues, learning from the first waves and implementation into current process. And then Caroline and Adam will be talking to us about our plans for recovery. So in terms of where we are with the pandemic right now, this is the national situation. As you can see, we are firmly and clearly in a third peak. Those of you listening to the news on a daily basis will recognise that information in the top right corner, that there's a projection related to the third peak that will hit at least 50,000 cases a day rate, and possibly significantly higher. And that's the national UK prediction. If you compare that to the peak that we saw in oh sorry, I'm just jumped ahead there by accident, do apologize. If you compare that to the peak we saw in autumn, the beginning of the second wave, you can see we're pretty much at the same level now as we were then. Now, this is quite a disparate picture across the UK, so for people's information. Scotland is significantly worse in this regard than England and Wales. And in fact, I heard that somewhere between 4 and 6 of the worst regions in Europe for current COVID prevalence are in Scotland right now. England is in the middle of the park. Wales is better and probably a couple of weeks behind the rest of the UK in the pandemic course. There is, though, a significant younger age predominance in terms of the individuals in Wales who have current COVID. The R value in Wales at the moment is estimated about 1.4 for community cases. Of course, it would be remiss of me not to mention the scientific the consequence of the football on the pandemic course, and in no way have I mentioned this as a England football fan. There were 300 cases identified in Scotland, which arose from the England-Scotland match, interestingly, and 20 only, though, in England. Just thought it's interesting that people might think the consequence of the football was greater. That was the ones that from Wembley, although there was, of course, a lot of social mixing in Scotland, which may be contributing to their current issues. In terms of the Cardiff and Vale situation, we are currently seeing a significant rise in our incidents. The case rates are approaching 123 per 100,000 in Cardiff and 96 per 100,000 in the Vale. Test positivity very high in youngsters, although that may stabilise in relation to discontinuation of university term. Of the information, the really interesting last point there, based on our data, 21% of the new cases in Cardiff and Vale had received both vaccine doses. So it's about 80% had not, i.e. had either received no vaccine or one dose only. And if you look at the contemporary rate in Cardiff and Vale, that is the monitoring graph. Well, it's a couple of days old because it takes a couple of days to come through, but you can see there's definitely an upturn in relation to the current prevalence. The age mix in that is as follows: predominantly 25 and under, and then dropping off as you get older and older. And of course, that has a direct consequence on the consequences of infection. Finally, the test positivity rate by health board, as you can see, dipped and is now going up across the board. All health boards have an increase, and today's level, hot off the press, was just over 7% test positivity rate in Cardiff and Vale. Now, if you then look at the vaccination status in Wales, over 2 million doses of vaccine have been given to someone who's had at least a first dose, and of those, 1.7 million or so have had 2 doses. That means that over 90% of adults over 18 have had at least 1 dose, and over 66% have had at least 2 doses. So an incredible performance in vaccination. So in terms of how that pans out, what does that mean is likely to be coming our way in due course? Well, there is some modelling available to us. It came out just about 10 days ago or so, and the modelling has included a number of variables which give us different models, and as per always, a minor change in some of the variables leads to a very significant change in the model consequence. But what you can see is the 4 model variables included here are the school opening schedule, the vaccine uptake, the variant assumptions in terms of the predominance of higher risk variables, higher risk variants, and the vaccine efficacy against those. And if you then, and from that, you can calculate these 2 things. You can calculate the most likely scenario, MLS, and you can calculate the reasonable worst case, RWC. Now, the blue dotted line is the June, i.e. the new reasonable worst case in terms of symptomatic case incidence. The pink line is the most likely scenario in terms of June community incidence. The grey and green lines are the previous model. All right. And so what you can see is that there is cases will increase, and they might increase to a level higher than previous waves in the worst case. Now, what does that mean in terms of admissions? Well, we can look at Scotland right now because they are, as I say, further on in the pandemic than we are. And what they are seeing is something along this line, that 3% case admission rate in Scotland compared with contemporary variants, but with a shorter length of stay. And what they're seeing is in the UK wide, a 2 to 3 times lower rate of admission per case than was seen in peak 2. So that's somewhat positive, and that actually comes out in the admission rates. Again, if you remember the graph I showed comparing the community incidents autumn last year to now, and they were basically identical, the admission incidence is very, very different. And so clearly the consequence of 2 things, really, consequence of vaccination and the consequence of the lower age cohort who are actually getting infected, the combination results in a much lower admission rate per case. So where are we right now in terms of Welsh and Cardiff admission rates? On the left here, you can see the admission rate for hospitals in Wales. Now, all of these things take a little bit of time to come through, and so there's always a bit of variance between the graphs, but fundamentally what you can see is the hospital admission rate, 7-day rolling average, remains low. Likewise for critical care admission rates for COVID on the right. And if you look at the CAV specific data, there's just been a slight upturn just over the last week or so, although in absolute terms the risk remains low, and we're keeping a very close eye on that. Now, of course, everyone who works in the organisation right now will rightly say to me, yeah, but hang on a minute, we're really busy. And you're right, we are. And what this graph shows, and many of you will have seen previous iterations of this, is in yellow is the total non-COVID admissions, unscheduled care. And what you can see is, also it's EU attendances, do apologise. And what you can see is the number of EU attendances is now up to pre-COVID levels. And it's the first time it's been there since the pandemic started. So the EU activity is at a very high level. That is not associated, but the COVID level, as you can see, remains steady and reasonably low. Now, in terms of how that pans out with predictions, so this is again the same modelling with the same assumptions. Reasonable worst case under the new model is the blue dotted line, and most likely scenario under the new model is the pink line. And this shows that we would expect a lesser effect on admissions compared to the previous peak, even in the context of a higher number of community cases. But look at the scale, that those admissions do go on for quite some time. So a sort of rather protracted course associated with the most likely scenario, which, as I say, is in pink. So if we move on to mortality, and will pass, would you? I'm not sure what that is. If we move on to mortality, the estimates that we've seen nationally, the mortality rate per case so far in peak 3 has been 10 times less than in peak 2. And that is, again, a consequence of vaccination, of course, and the lower risk profile of those who are infected. And it comes out at the current mortality rate approximately 1 per 1,000. Now, I'm just going to take a slight deviation here, because another report has been published today, I believe, from the Health Foundation, looking at the overall mortality risk associated with the COVID pandemic today. And it does have relevance in terms of where we're going to go on to our future predictions. Now, this is the cumulative excess mortality. So the total number of additional people who have died above expected per country, expressed per 100,000 of population. And what you can see is that United Kingdom comes out poorly. So third only to the United States and Spain in this analysis of those specific countries. The timing of lockdown and the regional and international travel were the biggest factors in accelerating spread of COVID, as seen by this. But what we've got to remember is the starting point between all those countries is not equal. Nevertheless, the consequence of that excess mortality is that for the first time since 1976 in the UK, there were more deaths than births in 2020. So this is clearly, an important consideration in terms of those excess deaths. So why are we not starting from the same point? We're not starting from the same point because, of course, we have different prevalences of underlying health conditions which are associated with poor COVID outcomes, and some of those have worsened in the last decade. So we're starting from a point where we have an increased burden of disease, and you can pick any number of these which show a potential difference in the United Kingdom prevalence and the European average prevalence. Chronic respiratory conditions obviously being a key one, which has a 4.5% higher rate in the UK. So the population is at greater risk potentially. Now, the next graph shows the relationship between poverty and mortality from COVID. And what you can see is that there's a stark difference in the health of the working age population. That's what this is, with deaths. So that's the pink one. With deaths 4 times higher in the group living in poorest conditions from COVID. And of course, again, the underlying degree of poverty in a country will affect that overall excess mortality, therefore. But what you see is, if you look at the best point on the graph, this is the best fit of the graph of excess mortality per country versus the poverty in the country. And UK is an outlier, I think, on that graph of having a significantly higher mortality rate compared to its status in terms of poverty. So clearly, I think there's been some important consequences of in terms of flagging up the underlying inequity in the UK in terms of those mortality rates. Just to flag up, in addition, the impact on different sub cohorts of society. Firstly, 6 out of 10 people who died in that timescale of COVID had some form of disability. Secondly, there is a very significant relationship between ethnic origin and risk. In the first wave, manifesting in Black African men, and in the second wave, Bangladeshi men. And of course, a significant relationship with age. Now, what does that mean for Cardiff? Well, in Cardiff, the excess deaths is as outlined here. You can see that the predicted deaths is sort of the light blue line. The COVID deaths is the pink line, and therefore the cumulative and the cumulative all deaths is the dark blue line, and the excess mortality as identified with those peaks appropriately associated with the 2 peaks that we've seen. So not a great story in terms of excess mortality in our local environment. In terms of the future prediction for increased mortality for Cardiff and Vale, for Wales, that's outlined in this final modelling slide. So again, reasonable worst case in blue dotted line, and the most likely scenario in the pink line, and you'll see that there is at least some increase in mortality associated with the 3rd peak. So that's the slides really in terms of where we are. Of course, what that hasn't considered is the consequences of release of lockdown, and the modelling has, but my talk hasn't. So in terms of where we go from here, people have seen the suggestion of reduction, not the firm decision yet, but the very likely outcome of removal of almost all constraints for lockdown in mid-July in England. Scotland are following suit largely with some caveats. They haven't finalised their decision yet about what they're going to do, and I think the same caveat would apply to Wales. And if you saw what our Minister of Health said yesterday, she did say that we're going to have to learn to live with COVID as an endemic disease, and that at some point we need to release a number of those components of lockdown. What that actually means for Wales, we don't yet know, but it's certainly going to be at least a significant degree of release, I suspect. So that was my summary. I hope people found that of value and might have seen something they haven't seen before in the news outlets. Happy to take any queries and then move us on once we've covered any outlying issues to Jason and Gavin to talk about our IPC scenario, learning from first peak and proposal for going forward. So if people want to either put their hand up or put anything in the chat bar if there's anything they wanted to ask, and we can go from there. Jonathan. You're muted, Jonathan.
18 months in, I still can't get it right. I do apologise. I hope you can hear me now. Thanks, Stuart. You may be covering this later, but obviously staffing is very thin on the wards. We've got loads of extra beds in medicine. And if we get a rise in deaths, then we'll definitely have a rise in cases. So what's the operational plan with regards to where the patient's going to go, who's going to look after them, and what elective activity is going to be changed to manage that?
Okay, so we are covering, so Caroline and Adam are going to cover the operational plan going forward. That's mainly about recovery. But Caroline, can I ask if you could pick up that point with Adam at some point in your presentation? I don't want to sort of preempt what you're going to say. Is that okay, Jonathan, if we pick that up as part of that operational discussion?
Yeah, that'd be great.
And I think we have a number of trigger points for change, which will be, I see Alid's on the call as well, usefully, who may also want to come in at some point about that when we get to that point. So if I can just give Adam, Alid and Caroline an ask to pick that up when we get to that relevant point. Okay.
Just on that graph that you've got displayed there, is that for all of is that all Wales, or is that Cardiff?
That's all Wales.
Vale?
It's all Wales.
Okay,
yeah. So the modelling is done by Swansea on an all Wales basis. Yeah.
So for Cardiff, actually, the number of admissions per day is probably going to be, according to the most likely scenario, what, a handful a day, less than 10?
Yeah.
Let's have a look. Admissions, COVID admissions, most likely scenario, yeah. But of course, and the length of stay, as I say, on the Scotland data is shorter than peak 2, but nevertheless, when we get into the older age cohort, is likely to be a reasonable length of stay, and will therefore the net effect would be of a potential additional inpatient cohort, of course. Yes. Caroline.
Yeah, no, I was just going to come in on that point. So you're right, Jonathan. It is less than 10, potentially even less than that. We've got the teams now trying to take the All Wales modelling and applying that to the Cardiff data. So hopefully we'll sort of see what our specific curve will look like. Although it is likely to replicate that sort of pink line, which is low numbers but a long sort of tail to it. But so we'll get that out ASAP.
Brilliant. Well, thanks very much, Jonathan. Do you mind if no one else has their hand up? So unless there's any particular points people want to make, I'll move us on and ask Jason and Gavin to come in on the IPC issue.
Thanks, Stuart. I'm going to bend to Gavin here. He's undertaking the presentation, so he's going to present it to him.
So I've got to stop sharing. I'm trying to stop sharing. Oh, there we go.
Thanks, Chase. Thanks, Stu. So hopefully my presentation is going to open in a timely fashion. There we go. Everybody got that? Yep, good. Thumbs up. Okay, for those who don't know me, I'm Gavin Forbes. I'm one of the microbiology consultants here in Cardiff, and I'm the lead infection control doctor for UHW. So I'm just going to run over a few of the things that we've taken away from waves 1 and 2 under sort of 3 main headings, and then some recommendations for what we as an IPNC team would like to see heading into wave 3. So the first thing I want to talk about is the hierarchy of controls. So those of you who have read the new PHE 4 Nations IPNC guidance will know that hierarchy of controls is something that's relatively new into that guidance, and they talk about it a lot. Within infection control, it's essentially a structured way of thinking about how to reduce or remove infection hazards. It applies to lots of other hazards in the sort of the field of occupational health, but we use it in infection control for eliminating infections. So what you can see there is the hierarchy of controls on the left and how it relates to COVID-19 as an infectious hazard. So ideally, the easiest way of protecting people from a hazard is either to eliminate it, which obviously we can't do with a circulating respiratory virus, or substitute it. And we can't really substitute COVID-19 for a different respiratory virus. We probably wouldn't want to do that anyway. So what we're really looking at are engineering and administrative controls. And then at the bottom, you can see PPE. So what we really want to think about is moving away from having a lot of stress and concern about PPE, which is the least effective way of controlling an infectious hazard, and moving more into engineering and administrative controls, so structural ways that we can protect people from COVID-19 as an infectious hazard. So what we want to do is focus our efforts on getting those engineering and administrative controls right. So the problem with that is that they are potentially hard to institute and they can be hard to get right first time. So if you think about engineering controls, that's about how our hospitals are built and laid out. And obviously there's not a great deal we can do with UHW as it exists. We have used this process to feed into the capital planning process for UHW2. So it's nice that we've got some infection control input into that early to try and make it as safe from an infection point of view as we can. But there are a number of things that we can do with UHW as it stands. Looking at ventilation is something that's really important. So not necessarily just opening windows, although obviously that does have some small effect, but making sure that we are mechanically ventilating as many clinical and non-clinical spaces as possible. And those that we are having the appropriate amount of ventilation for the procedures that are undertaken, because obviously if we can remove infectious droplets and aerosols from the environment, then it doesn't really make a great deal of difference what else happens, because we're taking away that risk. The reorganisation of clinical and non-clinical spaces, particularly to maintain social distancing, is something that's been a challenge. The sort of work from home directive has really helped with that by reducing the number of people physically in the building so that we can space out those who have to remain in the building as part of their normal duties. We need to continue to do that. There was some discussion about how we might do that in clinical spaces, particularly during wave 1 and wave 2, essentially with regards to the lack of social distancing in ward areas. The majority of the resolution of that would probably be removing bed numbers, and obviously that's not something that's easy for the organisation to do, but it is something that we should continue to consider. The other issue is not about structures, is about people. Changing the way this is set up requires ooh, someone's taking control of my screen. Who's that? Let's see if we can have that back. So we're talking about behavioural changes. So it requires people to work in a way that they have done different to how they work for quite a long time. So social distancing obviously has been a big factor for everybody in every aspect of their daily life, and that's something that we need to be able to maintain within a healthcare setting, particularly where there are lots of people in very close proximity, and a lot of the people within our setting are vulnerable to infection. Working from home is a big challenge as well. Most organisations are not set up for routine home working, and that's been a big culture shift, and I think is probably something that will continue even as we level out of the pandemic, just to make sure that we are limiting the number of people who are in close contact with each other on a daily basis. Talking about PPE is a very emotive subject, and it can be a difficult conversation to have, but the evidence behind the hierarchy of controls tells us that it's the least effective control measure, because essentially what you're saying is that we can't do anything about removing people from the risk, but protect them when they have to be in contact with it. And obviously there will continue to be a risk in a healthcare setting, and we need to make sure that we are controlling that as much as we can. The good thing about PPE is that it's not as difficult to institute as big ventilation works or large-scale behavioural changes, so it can be done at short notice. But as everyone will remember, at the beginning of the pandemic, there was a significant issue around appropriate PPE being in stock and people understanding what the PPE that they needed to wear was. As such, the PPE cell was established as a joint effort between us in infection control, health and safety, occupational health, procurement and other teams to try and manage and optimise PPE use. And that streamlined how we were doing that so that we could protect our staff as effectively as possible. PPE guidance continues to be under review as evidence comes out, continually reviewed by the central infection control cell within PHE and the devolved administrations. And so things will continue to change on that basis. We are having some internal discussions within the IP&C world about modification of PPE guidance to account for specific situations, but there's nothing concrete on that as yet, but we're confident that the PPE guidance as it stands is appropriate. Then I'm going to move on to what we've learned from outbreaks. So as everyone will know, we had multiple outbreaks on all of our sites during both the previous waves. And what happened is those outbreaks tended to reflect community transmission. So as in other settings where there were lots of community cases coming into hospital, we would inevitably get outbreaks. Outbreaks are controllable and minimizable, but I don't think there's much we can do to stop them in their entirety. And as such, there was significant disruption to all the services within Cardiff and Vale, particularly hard hit with the regional and tertiary services. So, for example, in the renal and transplant services and cardiology services where they had multiple outbreaks in those areas, and those had a significant knock-on effect throughout South East and the rest of Wales. So what we need to do is make sure that we're understanding how we can prevent that from happening in future. Just a bit about the scale of the outbreaks that we'd encountered. So between April 2020 and March 2021, there were 59 ward closures within Cardiff and Vale, resulting in just under 10,000 bed days being lost, which obviously is a vast amount of service disruption. We think conservatively just under 1,000 patients and just under 500 staff involved in those outbreaks. And unfortunately, that was associated with quite a significant mortality. So the estimates are that hospital-acquired COVID results in a 25% mortality rate. We know that 44% of our inpatient COVID deaths were in those who acquired COVID in hospital, and the majority of our hospital-acquired COVID is linked to an outbreak. So what did we identify from learning about our outbreaks? So mainly that there are multiple sources of infection and there are multiple things that lead into it. There's no one main factor that resulted in outbreaks in Cardiff and Vale. So we know that there are structural environmental issues. Our hospitals are not well set out from an infection control point of view. They have large bays, relatively few individual cubicles. If you were designing a hospital now for good infection control practices, you wouldn't design it like UHW is designed. Lack of recognition, I think, is an issue, particularly early on in the pandemic when the case definitions were around travel and probably a significant number of patients who had COVID but didn't meet the travel related case definition were admitted, and we didn't fully understand that it was circulating in the community with quite the speed that it was. Also around a broad symptomatology. So obviously we know that there is the big classic triad of symptoms, but COVID does present atypically in a significant proportion of patients and they may not have been recognised in the early stages before there was universal admission testing. Transfer of patients from outbreak wards we'll talk about a little bit more in patient movement next, but we know that moving patients around from outbreak wards, even if they're not identified as a contact, is a risk, just because of the nature of respiratory viral illnesses. Transmission from staff to patients in long stay environments. So outside of UHW, if we think about St David's, Lansdowne, Rookwood, we know that there are patients who hadn't had contact with the outside world for a long time, and that we think that the route of introduction for those areas was staff, particularly in times where there was a very high rate of community transmission. And then PPE issues. So obviously we know at the beginning of the pandemic, PPE was difficult, but we've seen PPE issues crop up throughout the last 18 months or so. And we know that inadequate or inappropriate PPE had led to transmission both to and from staff and patients. So what did we do? So the problem was that we were very much in firefighting mode as an infection control team at the beginning of the pandemic. So lots of our outbreaks essentially went unresolved because we didn't necessarily know that there was an outbreak, or we didn't have the resources available to deal with them. During the beginning of wave 2, we were very clear about good quality outbreak management, and so a daily IPNC cell meeting was instituted, I think in September, where all the outbreaks were discussed, so that we had good quality high level management of all our ongoing outbreaks. But what we really want to do is make sure that we're preventing outbreaks, because that's the only way we can maintain good service continuity and flow throughout the organisation. So asymptomatic screening was introduced in the beginning of this year to understand whether we were having patients who are testing negative at the front door and then generating outbreaks further into their stay. That did grant us fairly significant benefits, I think, during wave 2, probably less so at the moment while transmission is low, just because of the likely false positive, false negative rates. But that might be something that we keep in our armoury for wave 3 if things pick up. And what we want to see is some clear communication and documentation around a lot of aspects. So understanding that patients may not have classic symptoms, and that might still mean that they've got COVID. Understanding how test results are obtained and communicated. We've done a lot of work in the laboratory to make sure the test results are as clear as possible so they're easily understood. And then understanding the balance between clinical needs and operational needs to maintain patient safety from an infection point of view, but also patient safety to make sure that their medical and or surgical needs are being met with service continuity. Patient movement is something that I wanted to pick up particularly because there is lots of documentation that shows that movement of patients is associated with increase in transmission. And if you move patients out of outbreak areas and into new areas, you essentially cause new outbreaks. It also increases complexity when investigating those outbreaks because we lose a simple epidemiological chain, understanding where patients have gone and how outbreaks have been caused if patients are moved around a lot. We know that difficulties in communication can result in inappropriate patient placement. We've had patients who've been tested at the front door, and then their results not been seen for 48 hours, and it turns out that they were positive 48 hours ago and have been put into a general medical ward and caused an outbreak. And particularly around the colour-based streaming system, the understanding of that is very inconsistent, and obviously patients who are thought to be blue or green and then turn out not to be being placed in inappropriate places leads to transmission events, and we saw that particularly during some of our second wave outbreaks. One of the things as an infection control team that we talked about during the second wave was admitting at risk. So that's where we know there's an outbreak in an area, but service continuity requires us to continue to admit patients into that area. And we have plenty of evidence that actually that prolongs or causes outbreaks because it was undertaken quite well in some areas, so particularly in our specialist or tertiary areas, where there was very clear oversight about who was making the decisions to admit to those areas. And it was not undertaken quite so well in other areas where there wasn't really an understanding of what admitting at risk meant. And so we need to go forward by balancing operational risk and infection risk, and that's something we're going to have to work closely with the operational team to manage. What we've also taken forward in the last couple of weeks is trying to work out how we can provide a risk assessment tool for patient movement so that we're moving patients as safely as we can between clinical areas and between hospitals. And I would hope that we would have that formalised within the next few weeks. So the recommendations, what we want to see is an increased emphasis on engineering and administrative controls to reduce risk of infection to staff and patients. So that's things that are relatively complex and have a long lead time, like improving ventilation, in optimizing layout if we can in clinical and non-clinical areas. To allow for distancing and keeping that 2 meters between patients to reduce risk. Reinforcing behavioural and social interventions is really important. Those are things that we can put in place and are very well adhered to when everybody's focused on it. But as focus slips, those practices also slip. And we need to make sure that we're doing everything we can from a behaviour point of view to keep ourselves safe. And the good thing about these is that once we get them in place, they provide a lot of resilience. We know that there will be more outbreaks, there will be more pandemics, and if we can get the engineering and administrative controls in place early, we're in a better position for the future. Our current outbreak prevention measures are working well. We haven't had a significant COVID outbreak within Cardiff and Vale for many months now. Our asymptomatic screening program, detecting patients before infectivity, is a good way of of preventing outbreaks. While we've got we've got a reasonable community prevalence, is less good at the moment, and we may review that as we go along. Recognition and discussion of potential cases is really important, along with safe patient placement, and we can continue the same high-level IP&C oversight. And then the last thing is about patient movement, so risk assessing before movement, having a clear and easy to use system, which may be the colours, which may not be the colours. We're still discussing that. And we want to eliminate the admission at risk setup and replace it with specific patient-centred assessments so that we can look individually at patients and work out where they need to be placed and what their risks are.
Gavin, thanks for that. I'm wary about time. I know you whizzed through at 100 miles an hour. There are 3 questions in the sidebar, one from Ivor, one from Jonathan Underwood and one from Chris on the ITU. I wondered if you could just put the answers in the sidebar for me so everyone can see that. and we'll ask Adam and Carolyn to move straight on to the operational update.
Yep, that's fine. I can do that. Thanks, Stu.
Thank you.
Yep. Thanks. If I could just share, if we could take this
You
previous
need, yeah, you
slide.
need to stop sharing.
Sharing, yeah, if that's all right.
There we go.
Excellent. Oh, there you go. Hopefully that's up for you. So I just wanted to run through you a high-level summary really today of our recovery and redesign annual sort of plan summary. I'll sort of take you through the slides, and then Adam will jump in or support in terms of just answering some of the questions. There is a much more detailed document that is available if people really want to read it, which is our recovery and redesign addendum to the annual plan. So if people do want that, let me know and we can send it through. I mean, the annual plan, and particularly the recovery and redesign element of it, is an iterative process. I mean, we developed this at breakneck speed. So this will, progress actually as we go throughout the year and also over the years. So it's probably just worth bearing that in mind. And the principles and the objectives on which the sort of plan is built is that we've taken the learning from COVID in terms of doing that, and particularly around the clinical leadership. Now, you as a sort of clinical body and a medical body did some amazing things during COVID, and I think recognizing that throughout the sort of recovery and redesign period, that is one of our key principles going forward. The other two principles then are our plans need to be data driven, and then also again recognizing actually the risk within the system. The plans need to be sort of risk orientated rather than our usual sort of approach to sort of time-based targets. You'll see there as well on the slide the sort of three objectives down the bottom in green that we're trying to meet. And then the other big thing, which sort of links in, I suppose, to Jonathan's question, was that we recognise now over the course of the recovery and redesign sort of period that for the foreseeable future we will need to remain COVID ready. So what you see in front of you here is basically our current and updated recovery, our COVID ready sort of operating model. This is built on the sort of operating models that sort of came in wave 1 and then were adapted and updated again then in terms of wave 2. And that sort of current sort of top box really hasn't changed in terms of our sort of, again, key principles and approach to our COVID readiness. We're still informed by surveillance data. So I mean, Stuart showed you some of that modelling from a national level, just in terms of the bed capacity. There are a whole other range of indicators as well on top of that. And in addition to that, there's also regional surveillance. And then we have our own teams actually taking some of the national and regional sort of modelling and sort of data and translating that into sort of key surveillance data for us, specifically for Cardiff and Vale. And then what that feeds into, if you like, actually is our early warning system. And this is the bit that we've updated now in terms of coming into wave 3, and in particular it's the triggers that inform our gearing and our sort of step up and change in terms of the operational plan. You'll see the 3 levels there. So the first thing we continue to look at is what the community prevalence is. We also then look at in terms of what the EU attendances are, and in particular the suspected admissions or suspected attendances into EU. But then I suppose probably the key for the in-hospital, I think the first one probably more informs, if you like, the sort of primary care and mental health. But the last one, and in terms of the sort of the COVID admissions, that really informs what we do within our hospital and the changes we need to make in terms of our footprint. So Jonathan asked there actually, what is our operational plan? So our operational plan in UHW, it currently is for suspected and confirmed cases. It is 1/2 of Hyelwyn currently. Should we need to increase our capacity based on this sort of last sort of trigger, we would, the next stage would be about flipping the other side of Hyelwyn from to COVID positive, and then the next stage after that, should we need it, actually is going back to the sort of previous model where we flipped a ward actually on the 7th floor. Aled, I'm not sure whether you want to come in at this point actually, just to sort of pick up on Jonathan's question.
Yeah, so I think in theory the 7th floor model and utilising negative pressure cubicles should be what we're thinking of doing, but it's slightly complicated by the fact, and comes back to the slide Stuart showed earlier, which is Amber. Amber is our major challenge. So non-COVID patients and scheduled care is our major challenge at the moment. As well as the backlog of patients who need to access tertiary services in places like gastroenterology. So I think if we have to go up to that 7th floor, then it will be C7 or A7 as we've had previously, and some discussions about how we move our Amber wards around to accommodate the ongoing Amber issues. And I think the added complication of this is what our winter looks like this year. So that there is that long COVID tail, which obviously will interact with our winter and flu and respiratory infections. So we need to sort of, as we go through the coming months, take all of that into consideration.
Okay, thanks, Aled. So then coming back, I suppose, to just the general sort of recovery and redesign plan. We've submitted the annual plan to Welsh Government, but it's probably worth noting, I think, the assessment of the scale of the challenge for us probably sees it in a sort of a 5-year plan in reality. I think Welsh Government are probably talking about it in terms of sort of 3 years. So it's somewhere, I mean, it's definitely outside of the yearly sort of approach. We've set up we've got a program approach to our to the recovery and redesign, and within that sort of overall portfolio, there are 5 key programs. And again, I'm not going to sort of read those out. You'll see those in terms of the boxes in front of you. But I suppose it's important, I mean, although they sort of look as though they're sort of segregated, if you like, and separate. I mean, this is whole system, and they all interlink. So I think having that sort of portfolio approach will be quite important, actually, in terms of making sure we get the linkages between all of these programs right going forward. And then alongside of that, I think we can't forget actually that our current configuration, and whether that's our footprint or service actually configuration is not as it was. So we've got services operating now from UHL, which we didn't have previously. Our ward environment, our front door environment, all looks very different actually, as we're having to put in place, I suppose, streaming of the different types of and categories of patients coming in. So we are conscious, I guess, actually although we've got a big sort of transformation and delivery program, alongside of that, actually, we've still got work to do around our configuration, and that's sort of in the more in the immediate term, and plus the over the course of the next months and years in terms of that. Just then very quickly where we are. So in March, we submitted a draft plan to Welsh Government. It was focused on planned care at the direction of Welsh Government in terms of that one. We had approval in, it was April, for £13.6 million to support the majority of the schemes actually that we put forward. And then again, we recognise this is an iterative process. So in May, we then started to look at the longer list actually from clinical boards across the system actually of all the schemes that we needed to implement. we had a very long list on in terms of that, and I'll come on to that in a second. So we undertook an internal review and then finalised that sort of system-wide approach of schemes into our recovery and redesign plan, which was submitted to Welsh Government initially as an early draft in mid-June, so they could get a feel, if you like, of the scale of our challenge and the scale of the particularly the budget actually that we were additional budget we were asking for. So we submitted that early June, and then we finalised our plan and submitted then at the end of June. We haven't had feedback yet from Welsh Government on that second iteration, but we are expecting that sometime early in July. And then from I suppose what I wanted to stress today is that this hasn't been a top-down approach to developing our recovery and redesign plan. This has been very much a bottom-up approach with the schemes coming forward from the service. So the output of the initial discussions actually from again coming forward from clinical boards was that we had, I think it was in the end actually, it was over 140 schemes submitted. Which would have cost, if we'd implemented them, 60 million in terms of that, and the majority, as you can see, at that were skewed, I suppose, actually to plan care, so 50% of the volume and also 60% of the cost. Given that we had so many, we went through a process really of just trying to sort of focus, I suppose, on schemes which were related to COVID, because that was in line with the Welsh Government guidance. So this wasn't about trying to seek historic finance or to correct historic finance or resource gaps in services. Welsh Government were very specific that anything we put forward for a request for funding needed to be related to an impact of COVID. So we gave that as qualifying guidance, and then we looked at it, I suppose, over three sort of categories. The first one being risk and urgency. So if the scheme basically mitigated a clear clinical risk, or there was a scale of need and benefit, and it was deliverable, then we put the scheme forward. The second thing we looked at then was about sustainability. So if there was, again, if there was a requirement for an ongoing investment in core service, etc., again, then we assessed the scheme should go forward. And then finally, we looked at those schemes actually which were embedding, I suppose, actually some of the, the alternative ways and new ways of working, which sort of met with our strategic direction. Now, schemes actually, those aren't exclusive categories. A number of the sort of schemes actually touched all three, and so again, we're sort of barn door for us going forward. So what we put forward, just to give you a sort of scale of what we put forward, this slide just shows the summary in finance terms of our bid into Welsh Government. So you'll see there for 21-22 in total, we're asking for 37 million. And then going forward, actually, again, recognising this is not a, this isn't a 1 year recovery. This is much longer period than that. We've asked Welsh Government for 40 million. In terms of that one, to date, we've had, as I said, we've had confirmation of that 13.6 million. And I suppose that I'll come on to a couple of slides now, which will take us through of the new schemes, of the 24 million of new schemes in the sort of second bid, really, that did cover a much broader whole system recovery, as you'll sort of see on this slide now in front of you. So you can see there in the first submission in March, actually 69% of the schemes we put forward were focused on plan care and 29% diagnostics. But actually in the June submission of the new schemes there, you'll see actually it was much more focused, if you like, actually across the whole system, with 45% actually coming from primary care and mental health of the new schemes, and then the pie chart on your right is just showing you the sort of total value. I think what's probably important to sort of note is that the plan, I guess, actually is iterative and progressive. So it starts to shift when you look at both months and year on year. So again, here you can just sort of very quickly see actually that we start, if you like, actually to shift from the sort of the planned care element, etc. That becomes a much smaller sort of chunk in year 2, and start to sort of move, if you like, actually to the sort of primary care element within that. So I suppose these slides are just to sort of show you the progressive nature, I guess, in terms of the plan, and then just in terms of the last bit of this, you'll see here, and just in terms of those 3 categories I've talked about again how that changes with year 1, if you like, this current year, much more focused on risk and urgency with 46%, but again recognizing actually that we need to be much more transformational, and we need that the sustainability element is important. Those grow as we go through the year, and I suspect as we go into where we're on 23, 24, again that mix will be will change again actually as we go throughout the years.
Carolyn, I'm afraid we've hit the buffer time-wise, despite us all going as quickly as we possibly can. We overstretched ourselves as per usual. So I will have to stop you then. What I'll perhaps do is say that anyone who wants to hang on, we're happy to hang on until we've answered all the questions. Well, I am anyway, and I suspect colleagues will be too. So if you could stop sharing, Caroline, and then we'll open it up. And would people like to put their hand up or put something in the chat bar, and we'll just pick up any questions on any issues that you've heard, pandemic course, IPC, operational delivery going forward, anything you like, just to finish up. Sorry about the short question and answer session, but we talked too much as per usual. I was more guilty than everyone else. Right, who wants to kick off? Nobody? Anyone got any comments about what they've heard? Any reflections? No? Oh. Is that something in the chat bar? Who's that for? Something about the last summary slide? Dawn, did
yeah, just in terms of where we are, in terms of the programme, did you just quickly want to touch on that?
Dawn, did you want to just say out loud what it is you're asking?
Hiya, hi. No,
Hi,
it's just because there's so much that you were talking about, Caroline. It would be quite good for you to sort of, tie things together,
Go on then, put your last summary slide up, Caroline.
Yeah. Well, I'll just talk through it, and then what I'll do is I'll send the slides around to you all. That might be the easiest way to do it. I mean, where we are in terms of summary, so we've got the programme approach in place. We've appointed a programmes delivery director who starts with us now in mid-January, just in terms of overseeing that. But I think the key points really for you as a group is that we've given the go-ahead to progress with the schemes that obviously Welsh Government have given us the money for, so those schemes in the 13.6. But even more importantly, I think actually we're not waiting for Welsh Government approval for all of the schemes in the plan. We've been given the approval from management execs actually to utilise any slippage in terms of pushing forward some of the other schemes. So that doesn't mean that doesn't mean we're sitting and waiting actually for Welsh Government approval for the schemes that we think we just need to get on with, particularly those in the risk and urgency category. The bit in terms of medical workforce, there's a huge recruitment campaign we're going to need now. So the plan actually is made up of, I think we'd need to recruit, I think it's just over 300 whole-time equivalents, and I think the medical element that is between 40 and 50 actually. So again, we're not waiting for Welsh Government approval for that. We're working with our colleagues in workforce currently actually to recognising the lead-in times to start recruitment processes where we can.
Okay, thanks, Caroline. I think Katie's put in a very pertinent point on exactly that issue in the chat, but I don't know if that was deliberately coordinated, but it seemed to be very well. So she's flagged up the issue about staffing. I wonder if I might come to Alid again. Alid, I'm sorry to put you on the spot. The question from Katie does refer to sort of middle grade physician staffing, which I think is a key issue that a number of people are concerned about. Did you just want to give us any heads up in terms of either a contemporary recruitment plan or indeed any news about trainee allocation that you think might be of relevance in that regard?
Okay, so I mean, Katie will know our position in medicine, and it's not great at the minute given our reliance on locums through the last 18 months for uncommissioned areas, as well as the fact that our trainees are all now rapidly trying to sort of get their annual leave in before the end of their rotations prior to next year. We have been lucky with some increased allocation from HIW. Obviously, they're not fully funded, but partially funded because they'll be going on to on-call rotas as well, and should help sort of make our on-call rotas a little bit more resilient. And then coming into next year, our intention is to over-recruit off the back of the locums that we're going to need to put in place, cognizant of all the issues that I mentioned earlier: COVID, winter, respiratory illness, return of respiratory illness, and a site-specific issue, and for UHW in terms of the acuity of patients arriving here, and a rota-specific issue for Llandoch in terms of the numbers needed at night. So you wrap all of that into a workforce plan, you realise we're nowhere near where we need to be in terms of training grade level doctors. And that's not to say we need doctors for all this, because we could look at other options with nursing colleagues and PAs, for instance. I know nursing colleagues have their own issues and are talking about those things. So we want to look at those mixed models. But the immediate intention is to go at risk for a large number of training grade level doctors for the coming year, offset against the numbers of locums that we've been shelling out for in the last year, with the hope that that will be popular for kind of F3 level doctors. Now, the issue about middle grades is much more difficult, Katie, because there aren't middle grades out there who are sitting waiting for us to make them an offer, unfortunately. So we kind of have to think creatively about that, I think, and return to our principles of how we managed the second wave. And you guys in respiratory did that really well. We split off rotas, we split off COVID and non-COVID teams, but I think we need to be careful about that going forward in terms of what HIW are allowing us to do in terms of relocation. And then I think there's some other things to do about when looking forward in that modelling, when our busiest time is going to be, when our challenge is going to be, and for us to have some honest conversations about a system in our system as to how we can support each other. And you know, I think that's what we'll need to do going towards the winter.
On mute. Thanks, Alid. I'll move straight on to the next question. Nye.
It's not so much a question, more of a comment. It was just the fact, we need to think about the COVID patients requiring AGP or high flow nasal oxygen. Pre-COVID, these patients would have necessarily been managed in a ICU footprint. And it's just one thing as an organisation you may need to think going forward in terms of staffing, because these patients are critically ill and a proportion, about 1 in 3, required urgent intubation. Now, we obviously set up the 7th floor as a way of buffering our relative lack of ITU beds, such that our ITU really looked after intubated patients. But going forward, I think some thought has to be had around where best to manage the low numbers of patients requiring CPAP or high flow nasal oxygen, whether that should really fit under the medicine clinical board or whether that should be more on the intensive care footprint.
Any comments on that, Alid? Or did you? that sort of patient placement of those higher risk sort of AGP type, because I hadn't really considered that we'll be moving those off of the current plan. I don't know whether there were some other discussions had gone on.
So I think there have been some discussions based on ICNAC data, I think, from ICU, which and perhaps an appetite for ICU to take those patients earlier. We haven't really thrashed that out. I know there was a meeting on Friday afternoon, which I couldn't get to. Maybe some ICU colleagues on the call. Tom's here, so may want to make a comment about that.
I could just say that I am going to be meeting with Tom and Sabine just to discuss this when the numbers are low, to thrash this out, and then obviously get back to you on Elliot when we have a clear idea of what can be offered and when best to place these people going forward.
Yeah, just to add to that, yeah, so I agree with Adrian. Actually, these patients are critically ill. They need to be near an intensive care unit at the moment. They're 4 floors away. We don't have a solution for that at the moment, but the starting point for that is for us to meet and decide what's best for these patients. But I think the interim, the solution we had during COVID is not ideal going forward. So we just need to work that through.
Great, thanks. So as you say, Nia, you're meeting with Tom and going to come back with a recommendation. Is that the plan?
Yeah, so we're trying to get a date in the diary in the next couple of days just to discuss this through, following on from our meeting on Friday, which included the respiratory physicians as well as ICU.
Okay. Well, look, a massive strength that I think this organisation has and has really utilised to a great degree during the pandemic to date, and we have no intention of changing, is solutions to problems coming from the clinical body and us identifying the right approach with the people delivering services. So if you have a recommendation for a better way to do things, then we'll all be here. So please do go away, have that discussion, let us know what you think. Great. Well, thanks everyone. If people are willing, we've got another. We can take another question. Should we say one more before we have to finish up in case there's anything else anyone wanted to add? Jason, Jason, is there anything you've been very quiet? I just wanted to make sure if there's anything you wanted to add from the IPC perspective into some of those questions that appeared, or if we wanted to finish up now.
No, I've got nothing to say. Just thanks to everybody for the hard work that they've done really formally, but Gavin covered it all off in the presentation, and I can see he's answered a number of questions in the sidebar as the meeting's progressed.
Okay, and if anyone had any further issues they wanted to raise about IPC, they could come back to you and Gavin about those by email. Yeah, okay, thanks. And I'm not sure if Adam is still on the call. No, okay. Well, we can send out a summary. Yeah, of course. Yeah. Well, look, thanks everyone. Great session, great participation. Really grateful for all of that, and many thanks for everything you continue to do, and with in what can only be described as very challenging circumstances. So many thanks. Have a good afternoon.